calculating axis, we can actually double check our findings. So we have gone through all these steps. We've found this big broad quadrant. We've found our like teeny tiny cute little isoelectric lead. We found the closest lead to that. We've narrowed in our vectors, so we've got that big thick blue line. We've got that perpendicular red arrow. We've narrowed it in a little bit. We have adjusted 10 degrees or 20 degrees positively or negatively. Don't add or subtract. Remember that. Please don't add or subtract. We're just going away or towards our isoelectric lead. And now, well, we can double check. It's pretty easy to double check our findings and kind of make sure that what we found was what we found. So we look at our arrow, our axial arrow, that red arrow that we drew perpendicular to our isoelectric lead on the hexaxial diagram, and looking at the arrow where it ends up, wherever it ends up after our adjustments, the lead closest to that arrow on the hexaxial diagram should be the tallest on your 12 lead. And the lead opposite to that arrow, if we shot it backwards, should be the deepest QRS complex on that 12 lead. And we're just talking about the limb leads right now. So lead closest to the arrow, and those limb leads should be the tallest of those limb leads. The lead opposite the arrow should be the deepest of those limb leads. For example, just taking a static example, we've got our hexaxial diagram up here. We picked AVR, and this is just an example. AVR as our isoelectric lead. We're in the left axis quadrant area. We ended up at negative 60. Well, what is the closest lead to this arrow? And it's AVL. So AVL should be the tallest, should be the most positive of all the limb leads. And if I went all the way in the opposite direction, lead 3, right down here, should be the deepest. And that's how we double check ourselves. So AVL should be the tallest, and lead 3 should be the deepest in this example. In this one, right, we picked, I'll say AVL, looks like, as our isoelectric lead. We ended up right here at like 100, I don't know, 110, 100, maybe negative 100 degrees. Well, which one is closest to this arrow? AVR is our closest. So AVR should be the tallest. And then if we follow it down, AVF should be super negative, and so should lead 2, because if we follow this down, we would kind of fall in between AVF and lead 2. So lead 2 and AVF should be the deepest. AVR should be the tallest. And that would make sense. If my electricity is going this way into the extreme right axis quadrant, AVR is going to pick that up as a positive complex. So AVR would be the tallest, AVF and lead 2 would be the most negative. Let's go through our 3 examples once again. Example 1, we are in our normal quadrant. Lead 1 is up, AVF is mostly upright, so we're going to call that up and up. We're in our normal axis quadrant. We picked AVF as our smallest, cutest, little teeny tiniest little amplitude lead. That's my isoelectric lead. And then I drew my arrow at a perpendicular angle to 0. We adjusted it a little bit, a positive 10-degree adjustment. We ended up at positive 10 degrees. Well, looking at this, which is the closest? So lead 1, and that's been kind of blocked out, but lead 1 is right here at 0 degrees. Lead 1 should be the tallest. If we go all the way over into the, kind of go backwards from the arrow, AVR should be the deepest. So lead 1 should be tallest, AVR should be the deepest, and lead 1 is indeed the tallest lead of all our limb leads, and AVR is indeed the most negative of all of our limb leads. In example 2, we're in the right axis quadrant area. Lead 1 is negative, AVF is positive. That puts us in the right. We chose AVR as our isoelectric lead. There's our big thick line. And then we drew our arrow to a positive 120 degrees. We said that AVR is mostly positive. It's a little bit more positive than it is negative, so a positive 10 degree adjustment. Went from 120 degrees to a positive 130 degrees. So which lead is the closest to that arrow? It's lead 3. That should be the tallest. If we go the opposite direction, which should be the deepest, should be AVL. That's the closest one we're at. So lead 3 is indeed the tallest of our limb leads, and AVL is indeed the deepest of our limb leads. And then in example 3, we ended up in our left axis quadrant. Area lead 1 is up, AVF is negative. We are there in the left. We picked AVR again. It's our isoelectric lead. There it is. We drew our arrow into the left quadrant area. Ended up at, we started out at negative 60 degrees. We said AVR is completely negative, so totally negative. That's a negative 20 degree adjustment. We're going to go away from AVR. So we ended up at a negative 40 degrees. If we are at negative 40 degrees, which is our closest lead to that arrow, that's AVL. That should be the tallest. If we go in the opposite direction, which is the closest there, it's going to be lead 3, so AVL should be the tallest. Lead 3 should be the most negative. So AVL is probably kind of a tie between lead 1 and AVL, but if we measured it out, AVL certainly the tallest, and lead 3 is the most negative. Now let's talk briefly about some causes of axis deviation and kind of dig a little bit deeper into left axis deviation. So you saw at the very beginning of that quadrants video lecture that there's a little bit of kind of like overlap between the normal and the left axis quadrants. That's because we're going to take that left axis quadrant and we're actually going to divide it up a little bit into a physiologic and a pathologic sides, we should say. So the physiologic is 0 degrees to negative 30 degrees. Pathologic is going to be your negative 30 degrees to your negative 90 degrees. Physiologic is completely normal. Normal in a lot of people, nothing to be concerned about. Pathologic is something made that happen. That's not normal, and that's something to pay attention to. And how we determine that is you can just look at the number you calculated, the number that the computer spit out. And so 0 to negative 30 degrees is okay. Negative 30 to negative 90 is not okay. Something's pathologic, something wrong. If we were to look at the EKG itself, we're going to look at lead 2. So in physiologic left axis deviation, we're going to have a left axis deviation. So lead 1 is going to be upright, AVF is going to be negative, but lead 2 is going to be positive. It's going to be upright. In pathologic left axis deviation, lead 1 is going to be upright. AVF is going to be negative, just like it is. But lead 2 is going to be negative. It's going to be down. So here we're now kind of splitting out and kind of extending this normal axis quadrant a little bit. We're still going to, from 0 to negative 30, we're still going to call this left axis deviation. We're just going to call it a physiologic left axis deviation. So we're saying it's outside the normal, but it's kind of like it's kind of a normal difference, right? We're all different. We're all unique snowflakes. It's just a little normal difference. Anything beyond that, negative 30 to negative 90, that's going to be a pathologic left axis deviation. So we're taking this left axis deviation quadrant and just kind of taking out a little pie slice and saying, you know what, that little slice of pie in the very beginning, that's still okay. That's still normal. But we're going to tag that as physiologic left axis deviation. So it's not completely normal axis. It's a little bit off, but it's still kind of like a normal off. It's an okay off. The most common cause of left axis deviation is going to be a left anterior hemiblock or left anterior fascicular block. We'll talk about that here coming up in the next week or so. but that's the most common cause. There are also these ectopic beats, these kind of weird rhythms, ectopic rhythms, that will cause some left axis deviation. So this is going to be your pathologic left axis deviation. Again, physiologic left axis deviation, that's 0 degrees to negative 30 degrees, where lead 2 is still upright, still positive, completely normal. We're not going to worry about that. This is our pathologic left axis deviations that we're going to pay attention to. On the other side, right axis deviation might be completely normal as well. So, kids, adolescents, children, completely normal. So you might do a 12 lead on, a 10-year-old and see right axis deviation. Don't freak out. That's probably normal. Even you guys, 20, 21, 22 years old, it might be a normal variant for you to have right axis deviation. Had a class, a couple of years ago where we were doing 12 leads on each other, and did a 12 lead on one of the students, and came out right axis deviation, and everyone freaked out. It's like, you know what? No, he's completely healthy. he's just, you know, he's just younger and completely normal in the younger population. Um, Other than that, if you get to be my age, right, right axis deviation not so normal. So might be some ventricular hypertrophy, might be a posterior hemiblock instead of the anterior hemiblock or fascicular block. So posterior hemiblock or fascicular block that we'll get to here in a week or two. Might be dextrocardia, big fancy word that means your heart is on the wrong side of your chest. So you're kind of looking at the opposite view of it. Hopefully, the patient knows that they have dextrocardia and can tell you. If they are unconscious, can't tell you, you might see, you might see this and think something weird is going on. But every dextrocardia patient is going to know that they have dextrocardia for the most part. And then ventricular rhythms. Any rhythm that starts in the ventricles is going to go in this like weird aberrant pattern. It's going to go in this like um, counter upstream flow. So you're going to have this weird deviation. So you're going to have right axis deviation, extreme right axis deviation with ventricular rhythm.